All right, so we're still in the pulmonary section and we're talking about perfusion and pulmonary regulation. So really ventilation and perfusion and like our VQ ratios. And then, so we'll get into that. And then how respiratory or ventilation rate is regulated. So to start, we're going to consider the lungs and we're going to think about what's going on in the lungs and that we have blood moving through the lungs and we have air moving into the lungs through our mouth and our nose and our trachea. Okay, so we have air coming in and we have blood moving through. So each of these have their own pressures. Okay, so the air moving in has pressure and the blood has pressure. All right, so they fight sometimes, not really. But the pressure moving in, so we have a concern about in the alveoli, how much pressure is in that alveoli, and that's going to be pushing out. And then we have perfusion of blood past the alveolus, or the alveoli, and can we cause so much pressure into that alveolus that we actually push down and crush, I guess, or at least restrict flow through those capillaries. So that's the question that we have, and of course the answer is yes, and the more accurate answer is sometimes. All right, so if we think about blood flowing through the lungs, then we have this situation of gravity pushing down. Okay, so if the blood is moving through, you're going to have higher pressure blood moving through the bottom and lower pressure blood moving through the top. So zone 1 is lower pressure, so we're going to call that arterial pressure. So arterial is going to be moving through this side. Okay, so arterial pressure moves through here, and then leaving is going to be venous pressure. Okay, so one thing we know for sure is that, okay, let's erase some of these arrows here, is that arterial pressure, okay, so that's small a, arterial pressure is always going to be higher than venous pressure. Okay, so we're always going to have higher pressure. So where does that leave us with what we're going to call alveolar pressure? Because that's what we care about. We care about how much pressure is in the alveoli, okay? Because that's what is moving past those vessels. So in where the pressure is lower at the top, and this is because of gravity. You don't see this effect when someone is lying down. You don't have this effect. But in the top of the lung where the alveolar pressure is lower, then what can happen is that, well, let me redraw this, is that the arterial pressure is lower than the alveolar pressure. So we have a situation at the top because of lower blood pressure that the alveolar pressure is actually pushing down on the arterioles, and really it's the capillaries, the arterial side of the capillary, and it's reducing or restricting blood flow through there. Okay, so you have a lower perfusion rate, you have lower blood flow. Okay, so we see that the blood flow is the lowest in that area, and it's also, you can see that the alveoli is also, the pressure is higher. See, the alveolar pressure is the highest of all of them in the top, and then you have your arterial pressure, small a, and then your venous pressure. So you're also pushing down on the venous side. Okay, so you're really restricting blood flow through the apex or the top of the lungs in zone 1. So due to gravity, when standing, your arterial pressure is lower at the top of the lung than at the bottom. So we already established that. So we have higher pressure down here at the bottom. So that makes in zone 1, the alveolar pressure is higher than the arterial pressure, and that's why the arterial pressure. So that's why it can't kind of push against that. It has a hard time pushing blood through there because the pressure in these alveoli is so high. It's also higher than the venous pressure, and so the higher pressure in the alveoli will compress those capillaries, and then it reduces perfusion. So perfusion is greatly reduced. Hemorrhage or like a positive ventilation, like if you have somebody on a vent, or something, and you have positive ventilation pushing into the lungs, can actually make them completely blocked. Okay, so it can crush them completely. You know, it's not going to like destroy them, but it's going to block blood flow through some of the zone 1 areas. All right, so let's look at, and maybe we can kind of already see what's going to happen here. So let's look at zone 2. So we have our arterial blood going in and our venous blood leaving. Okay. And we have our arterioles. Now, or our alveolar. So it says that the arterial blood is greater than the alveolar blood. Okay, so that means that these alveoli are no longer able to crush these arterioles, or the capillaries. So on the arterial side. So we don't have that issue. However, our arterial or our alveoli, still the pressure of the alveoli is still higher than the venules, or than the veins, venous blood. So we do have some blockage or compression of the veins, the venous side. Okay. So that's going to restrict blood flow. So you still have restriction of blood flow. You still have perfusion that is slower, but it's not as slow, or it's not as bad as it was, or low as it was in zone 1. So you kind of have this, what we're going to call medium, and you can already see where we're going. It's going to be higher in the next one. So we can already kind of figure that out. So if our arterial blood pressure was high here, higher than anything else, so it's not being crushed by the alveoli anymore, and then the venous was lower. So what happens in zone 3 is that the arterial blood is the highest, and then the venous blood, and then the arterial blood. Okay. All right. So let's just look at that. We'll just draw it out just because we're here. Okay. So that's our blood going in. It's our blood coming out. I don't know why I did this. I actually did this backwards with the colors. I'm thinking arterial, and I always draw arterioles as red and venous as blue, but really we're oxygenating this, so you can kind of flip it and make that correction. So anyway, we have, yeah, my brain just automatically goes arterial is red. So we have in the zone 3, we have our alveolar is lower than our arterials. So the arterioles are are open, and venous blood is also open on the venous side. Okay, so the capillaries, these are capillaries. So on the arterial side and the venous side are wide open. So that means you have very good perfusion of blood through that area. So that's where it's the highest. Okay. All right, so perfusion of blood is highest at the in zone 3. And the pressure of the arterioles and the venous pressure are both higher than the alveolar pressure. All right, so let's look at some other terms. Hypoxic vasoconstriction. So these are some other control mechanisms that the lungs have. So if we think about what's going on in the lungs, the partial pressure of alveolar oxygen can regulate blood flow. So if we look at how much oxygen is going into the alveoli, then we can kind of see that because that's the way it's supposed to be. So the oxygen is going in. So what we're doing with hypoxic vasoconstriction, so hypoxia means that you don't have oxygen, so your oxygen is restricted. Okay. So let's say that you have very little oxygen getting in. So the oxygen isn't moving in. So what can happen then is that if you think about perfusion of the capillaries moving through here, if you don't have oxygen coming into that alveolus, then why would you have blood flowing through here? Okay, so we can actually have vasoconstriction. So let's see, on the arterioles coming in. So we have smooth muscle. The smooth muscle can constrict those capillary beds and reduce blood flow to that area too. So in summary, what we're saying is if there's no oxygen in the alveoli, then we'll just constrict the vessels going past that alveoli because there's no reason to waste resources and push blood there when we can redirect that blood somewhere else to a healthy alveolus and get perfusion there. Okay? So that's the idea, is we block blood flow going to the unhealthy, okay? So no blood flow there, and we move it to the healthy or the alveolus that actually has oxygen in it. All right, so when the alveolar oxygen is low, lack of air reaching that part, it induces that vasoconstriction of arterioles in the capillary beds, and that's going to result in that low or lack of flow to the regions of the lung that have low ventilation. Blood is directed away from the areas with the low oxygenation, and it's redirected to areas that are well oxygenated. So that's why it's going to redirect it. It's going to be, this is too much resistance, and so blood is going to move to areas that are needed. Now, you know, overall, that's still not a healthy situation, but at least it makes the best of a bad situation. Okay. Of course, it would be better for overall oxygenation if all of the alveoli work properly all the time. So that's why it's kind of a compensatory process. All right, so here we have compensatory bronchoconstriction. So if we think about this, if we kind of do an analogy here, and we say that for hypoxic vasoconstriction, this is if we say that, you know, this is a Walmart or a store that so we're offering up. Let's make this the carbon dioxide, okay? Or no, that's going to be in the next one. So we have oxygen moving in here, and the oxygen is saying that we can't provide you with oxygen. So if this is your Walmart here and they're saying, well, we can't provide you with a sled, and then so there's no reason for people to come. So it just block off the road. Why, I don't know why I said sled, but if your store can't give you, maybe groceries would be more useful. But if the store can't give you what you need, then there's no reason to have a road coming through it. All right. So if we take that same analogy and just butcher it again on this with compensatory bronchoconstriction, then it's saying that so what you have with compensatory bronchoconstriction is that the traffic is blocked off. Okay. So if perfusion isn't taking place, so you have no perfusion, the road's blocked off, then there's no reason to keep the store open. Okay, so the store will shut down. So you'll have, in this case, you have the bronchoconstriction. So the smooth muscle around the alveola or around the bronchioles will clamp down, and it'll block that. It'll block movement of air. So then you just have reduced airflow in. Okay. So now since you don't have flow, so it really comes down to what comes first. In this case, the road is shut down first, so you don't have so you don't have perfusion. So the road is closed down, so then we're going to close down the store. All right. So the perfusion is shut off, so then we're going to close down the alveoli so they don't send air where they don't need to be. Excuse me. So there's another concept called shunting. Okay? And shunting is where you're not getting any air. Okay, so you're not getting any air, so basically that's just a shunt. It's just moving. So if you think about this as the lungs, so right to left. The right side of the lung is deoxygenated, and what we want to do for normal is we want that deoxygenated blood to move past the alveoli, pick up some oxygen, drop off some carbon dioxide, and then return here, with 100% saturation or whatever. We want it to be highly saturated. So, so what happens with a shunt is the shunt never reaches that area, and instead, so maybe this isn't supposed to be here. There are different reasons for shunts to appear. Some are natural, but some of this blood is going to be redirected right past that alveolus, and it's going to go over here where blood was maybe supposed to be 100% saturated, and it's going to dilute it. And let's say it's going to make it like 93% or something diluted. So it's going to be lower, and so that's what happens with shunting. So left to right shunts occur when oxygenated blood moves right side of the heart, moves to the So what we have here is a right to left. So left to right is the other direction. A lot of times this happens. This happens frequently in the heart. You can have blood that never makes it to the or it gets reoxygenated. So it's already oxygenated blood. We'll look at a picture of it. So left to right shunts occur when oxygenated blood moves to the right side of the heart from the left. So that means it's oxygenated again. Right to left is what we're seeing here, this example. So right to left is when deoxygenated blood moves directly into the oxygenated blood on the left side of the heart. And remember, of course, this is our left side because it's facing us, and this is our right side. So everything is anatomical or anatomic. So shunting, patent ductus arteriosus. So here are a couple of examples of shunts, and these are all left to right shunts. So this is going to be from the oxygenated side to the deoxygenated side. So left to right. So in the case of patent ductus arteriosus, so patent means open. So that means that in a fetus, there is really no reason to send blood to the lungs because the lungs are kind of clamped down anyway. So they're not really, there's no oxygen moving into them, so they have the that vasoconstriction, that hypoxic vasoconstriction. There's no oxygen in them, so they don't in the alveoli. So they're kind of closed off. So really, what we want is just, we're fine with instead of sending blood from the pulmonary side, we can just send it. We can just send it straight through the heart. It doesn't have to. It doesn't have to go through the lungs first. So because pressure is higher in the left side, we have a hole here from the aorta directly into the pulmonary artery. Okay. So what happens is because pressure is higher in the aorta, it pushes in the pulmonary artery, and then it's and that's going to cause that left to right shunt. So this is in a baby, but what can happen is people, when they grow up, this patent ductus arteriosus may not have been found when they were an infant, and it didn't close completely, and so they still have some of this aortic blood moving into the pulmonary artery. Okay. And so that means that it is being oxygenated again, even though it just got oxygenated. Okay. So this is in an adult. Okay. And we can see other examples of that. So treatment is block the prostaglandins that prevented the closure. So prostaglandins are there to prevent closure before birth. But then after birth, you're supposed to have those prostaglandins are supposed to go away. And if they don't, then they will prevent that closure. And usually, you want about, let's say, 3 months for it to completely close. So, a lot of times you can just give them prostaglandins. You can give them ibuprofen, and it'll, which is an NSAID, or even aspirin, and it'll block it. Okay, or it'll allow it to close, but not necessarily after you're older. Okay. All right. So some other shunting that happens in the heart. It's called an atrial septal defect. So it's the atria. So there's a septum that's kind of here between the atria, and if a defect in the in development can leave a hole here, and so again, because you have in the atria, you have higher pressure on the oxygenated on the left side than you do on the right side, then you end up with oxygenated blood moving over into what we would think of as being arterial blood, and that will then be reoxygenated again in the lungs. So there's something to think about with this. Okay. So blood shunts left to right again. So all these pictures are left to right. So too much blood flow to the lungs. So we had our venous return blood, and now through this atrial septal defect, okay, this hole, now we're adding more blood from the left side here. So we're actually pushing extra blood into the lungs. Okay. So that is what can cause congestion. So a buildup of fluid in the lungs. And then, you know, if it's not corrected, heart failure. So this is common in Down syndrome for whatever reason, genetics. And so typically it's found at birth, but not always. And you can just patch it, or you can do surgery to close that hole. Okay. And then we have, this is very similar, pretty much the same thing. But this is more common. This is ventricular septal defect, so now it's in the ventricle, which is very, very high pressure, so we have even more coming over, which means we still have the left to right shunt, but then you can experience that congestive heart failure. So that really needs to be repaired. Okay. All right. Let's see. Okay, so treatment, spontaneous closure, pulmonary artery banding, surgery. Okay, let's talk about VQ ratios. So ventilation, so we've been talking about it kind of on purpose, using the terms ventilation and perfusion all along. So ventilation is our air coming in, and perfusion is our blood moving through. So we want that to be at just the exact ratio. So we've already measured our minute ventilation, which is kind of how much air you move over a minute, and our perfusion, our cardiac output, which is how much blood you move over a minute. So we can take that comparison and we can come up with something called a VQ ratio. Okay? So how much air is moving in versus how much blood is moving through the lungs. So the ventilation, of course, movement of air into and out of the lungs. It's affected by activity of the respiratory center, which we're going to talk about. And then diseases, various diseases, thoracic cage disorders. So since we're talking about ventilation, that's kind of a movement kind of a thing. So things that restrict movement are really affecting our ventilation in a lot of ways, the actual movement of air in and out. And so we can also have air that has a harder time, you know, being perfused, that are caused by certain diseases. So ventilation is that movement of air. Perfusion is blood circulation and exchange of gas between the lungs and the capillaries. So if we have, if we're trying to, so this is what these pictures are trying to show. It's trying to show venous versus arterial blood. And this can be affected by, you know, interstitial. Interstitial just means within these tissues, so in this area. So if you have disease, infection, something like that can get in the way of those vessels moving through there. Acute respiratory distress syndrome, which is also preventing perfusion. Pulmonary edema, buildup of fluid. Pneumonia, which is just fluid kind of building up also. Then what we can see is if we look at these ratios of the V over Q, is that we can kind of see if we have interrupted ventilation. So if our ventilation levels are low, but our perfusion levels are high, then we're going to have a low VQ. Okay? So if we think of normal VQ, so everything is fine, but then you look over here, and you can see that there's a blockage. So this is going to be a situation where our V is lower and our Q is, we'll just say normal. Okay, normal or high. And so we end up with a low VQ ratio. So just by saying, so that's why I guess there's some power to this, is just by saying, okay, you have a low VQ ratio, then you can say, all right, then that means we need to increase ventilation. We need to get more air into the lungs because the perfusion, the blood is doing its job. These capillaries are moving past it, but because we have a low VQ, then our ventilation is not. Okay, so we need to improve the ventilation. So remember later, so we have this term, or remember earlier, we have this term shunt. And shunt happens when blood is just being moved from one place to the other and nothing happens to it in between. So it's just moving from, in this case, an area of low oxygenation to high, or high oxygenation to low oxygenation, whatever, because it's not changing. And so this is when you have complete blockage or complete collapse of the alveoli or the alveolus here. And so you just, this blood is just, it's just, taking a road trip, it's just, on vacation, and it's just going from here to here. Nothing happened. Nothing of any significance happened. It didn't get oxygenated. It didn't get to give up its carbon dioxide. None of it. So at least here, in our second example here, our first one is just normal. But in our second example here, there should have been some oxygenation, okay, because it was just impaired ventilation. So there was still some air in there, but not much. And here we call it a shunt because it's really, our ventilation is basically zero. Okay, so if it's zero, that's a shunt. Okay, and this is just our previous example was just low. Now, what happens if we have impaired perfusion? So our perfusion in this case is low and our alveolus is great. Okay. Wait, did I say that right? Yes, I did. So, so we have impaired perfusion, which means that our Q is low. It's low Q, and high V. Okay. So now we don't have a low VQ. When we had a low VQ, we said, oh, there's a problem with our ventilation. Now we have a high VQ, and we say, well, all right, that means there's a problem with the perfusion. So we're not perfusing as well as we need to. Now, if our perfusion drops to zero, then that's when we refer to this as just alveolar dead space. Because there's really no ventilation that's taking place. There's really, if there's no perfusion taking place, there's no difference between an alveolus and your trachea. You have air moving in and out, it's fine. The alveolus is working fine. You have air moving in and out, but there's no perfusion taking place. So that becomes dead space in the lung. Okay, so it's not really doing anything. All right, so let's just kind of keep going with that. Let's see. I had a note here. Ideally, blood flowing through functional capillaries, perfusion is oxygenated by functional alveoli, and that's ventilation. All right, so our normal VQ, the ratio is normally 0.8, so that means that our V over Q, if you divide that, our ventilation is a little bit less than Q, but they're actually, fairly similar as far as our minute ventilation and our cardiac output. So 0.8 means that alveolar ventilation is 80% of pulmonary blood flow. And these are both, the units for these are both in liters per minute, because that's how we calculate minute ventilation and how we calculate cardiac output. So normal VQ considers that the tidal volume, remember your tidal volume, that's just your normal at-rest breathing, your rate of breathing, and your cardiac output, the blood flowing past, are all within normal limits, are all normal, what we would call normal. So at that normal baseline, or at that normal level, your average oxygen is going to be about 100 millimeters of mercury, and your average CO2 is going to be about 40 millimeters of mercury. Okay, so that's high oxygenation, and this is low carbon dioxide. So if everything is working perfectly, then we have good, nicely well-saturated hemoglobin, and the carbon dioxide is remaining low. So we run into problems when there are problems with it. So let's go back to our VQ distribution in the lungs. So this is our zones, zone 1, zone 2, zone 3. And now if we kind of consider what our ventilation is, we can kind of put this into different terms and look at it, I guess, in a different way. Okay, so we already saw initially that blood flow was lowest in zone 1 and highest in zone 3. So remember, that was because our alveoli were pushing on the vessels and kind of constricting them. Okay, so that's why we had low perfusion. So if we say that we have low perfusion and we think V over Q then that means that our Q is a very low number. And if our ventilation, we're going to say our ventilation, so it says alveolar ventilation is a little bit lower, and that's true. There are fewer alveoli in the top part of your lung. They're a little wider, they're more open, maybe a little bit less efficient, but it's not much lower. Okay, the really big impact here is our Q. Okay, so if our Q is very low, then that means our V over Q is going to be high. So if our denominator, if our denominator is lower, then the number on the bottom is lower. That means the overall number is going to be higher. So this is going to be our highest VQ ratio. So we need to know that. So the highest VQ ratio is in zone 1. And look what that does. So look what that means in a practical sense. If you have good ventilation, so our ventilation is fine, but our perfusion is really, really slow. That means it's going to get really, really oxygenated. So there's plenty of oxygen up there in the alveolus. It's nice and big and healthy, but that blood flowing past it is moving past it really slowly. Okay, so that means that you've got plenty of time for gas exchange in that area. And so it comes out actually being very high. So it's the highest at 130 millimeters of mercury. Remember, we were saying 100. 100's fine. And our carbon dioxide is really low, can be as low as 28. Okay, so that's because our carbon dioxide is leaving the blood while our oxygen is moving into the blood, and our perfusion is slow. So that means that you get really good gas exchange with a low VQ, or with a high VQ. If your VQ is very high, but it may not be efficient because that 0.8 is the most efficient. That's going to get us 100% oxygenation. All right, so then if we look down here at zone 3, that's the highest. So our blood flow is the highest. Okay, remember, because nothing, the alveolus is not messing with either the venous or the arterial side blood flow. And so you have great blood flow through the lung in zone 3. Right? Our alveolar ventilation is higher. We have more alveoli. Okay, they're packed in there a lot more tightly in zone 3, and so we have good alveolar ventilation in that area. And as a consequence, because we have high VQ, we have high V, and we have high Q, we end up with a 0.6 VQ ratio. All right, so that sounds great, except it's a little bit too low. So our perfusion is maybe a little bit too quick through there. And so we end up with oxygenation only going to like 89. So remember, we kind of set 100 as a nice level, and we set 40 as a nice level for carbon dioxide. Well, our carbon dioxide is 42. All right, well, that's fine. Because really when we're talking about normal, we're talking about an average. Okay, so normal VQ, V over Q, is an average of all of these values. So even though zone 1 is very, very high, it doesn't have as much of an influence because there's less blood moving through there. Okay, and then zone 2 is kind of in between, and then zone 3 is going to have the highest impact. So really our 0.8 is closest to our zone 3 number just because more blood is moving through the base of your lungs. All right, so let's look at regional differences to VQ on carbon dioxide and oxygen. So this is kind of the same thing. We're still looking at zone 1, zone 2, zone 3, zone 1, zone 2, zone 3. But one thing we know is that oxygen and carbon dioxide are usually related. So usually if the lungs and everything is working properly, if they're working properly, then higher oxygen will correlate with lower carbon dioxide. Okay? And so that's what this graph is showing. It's showing that as oxygen levels increase, so remember oxygen has quite a range. I mean, it goes from 40 all the way up, in this case, to 150 millimeters of mercury in inspired air. So it's got this long range. Carbon dioxide we usually think of carbon dioxide as kind of moving in this range between 40 and 44. Okay, but really, there's hardly any carbon dioxide in inspired air at all. So that's why it can go down all the way to what we would call zero, because there's very little carbon dioxide in the air that we breathe. There's some, it's a fraction. All right, but we can still see that the range for carbon dioxide is not nearly as much as this range for oxygen, which is why the graph is wide. Okay, so we can say 40 to 44. We can actually say that 0 to 44. All right. So the VQ differences in the lung zones match what we would expect. So if we have mixed venous blood, that's going to be right after it returns from the cells, and so it's going to have the highest carbon dioxide, and it's going to have the lowest oxygen. And then as it gets oxygenated, the oxygen levels will go up, okay, and then the carbon dioxide levels will go down. So if you remember, our VQ is only 0.6 in zone 3. So we weren't really oxygenating as well. Okay, so 0.6 is very close to our normal level of 0.8, so it's close, but our perfusion was really good. We had great throughput, but we were not dropping off as much carbon dioxide. It was about 42. Carbon dioxide was about 42, and I can't remember what it said the oxygen was. Let's see, in zone 3 was only 89. Okay, so that's going to match up with about an 89 of oxygen and about a 42 of carbon dioxide. Okay. All right. So then in zone 2, we had better oxygenation. It didn't really give us any number. And then in zone 1, remember where our perfusion, so V over Q, our perfusion was very low, which means our VQ ratio was high. Okay. Okay, so it was about 3. So because we had that high perfusion, which could also be from low ventilation. So, but we had the high perfusion because the blood was moving through very, very slowly. All right. So yeah. So in this case, so I think I said earlier that a ventilation problem was with a low VQ as a ventilation problem. Well, in this case, let's see. It's a high VQ because we have our perfusion is moving very, very slowly, but our ventilation is okay. All right, so yeah, that matches. So inspired air is all the way down here at 0 because it just doesn't have any oxygen, and it doesn't have any carbon dioxide, and it has a lot of oxygen. All right, so some other VQ mismatches. So hopefully we're kind of getting the hang of this. So dead space means that we have a VQ, our ventilation is fine, but we have no perfusion at all. So I always like to think of this, if I think of dead space, I think, well, what's the difference between this alveolus and your trachea? And really nothing. There's just air going in and then air going out. It is dead space. It's not serving any purpose, okay? It's not an anatomical dead space. This would actually be physiologic dead space because it's supposed to be doing something, but it's not. So it's just because there is 0 perfusion, we're calling it dead space. High VQ means that you have good ventilation. Okay, so good ventilation but low perfusion. Okay, and then a low VQ is low ventilation and either normal or high perfusion. Okay, so blood is moving through, but there's really not a lot of ventilation that's going to take place. So you're not going to get good, you're not going to get good oxygenation of the blood here because the air just isn't there to do it. You're not going to get rid of your carbon dioxide with a low VQ because, again, there's just not enough capacity for that. All right, meanwhile, we said, going back one step, we said that with low perfusion, then yeah, you do have great exchange because there's all the air up there, all the air you need. So your oxygen is moving in, your carbon dioxide is moving out. As long as there's some movement through that area, you can have good exhalation of carbon dioxide moving out and good oxygen moving in. So then we have this concept of the shunt, and a shunt is just moving of fluid or moving of blood from one part to another. And so there's no oxygenation that takes place. If this was deoxygenated over here, if it was deoxygenated here, then it's also going to be deoxygenated over there. Okay, so no ventilation, no gas exchange, same composition as it had before. All right, so the effect of VQ defects in the lungs. So a defect will cause a compensatory response. So if a region becomes dead space due to that loss of perfusion, then as we saw earlier, then that ventilation may decrease, or blood will be shunted to just avoid that area. So that's what we see here, is we see that we have, this is our normal, so we have good V, good ventilation, and we have good Q, good perfusion. Here we have a loss of perfusion. Okay, so that's our dead space. Okay, so no perfusion. There's no difference between this and the trachea. Air moves in, air moves out, and there is no oxygenation. Our shunt, there's no difference between this and a ventral septal defect. You've got blood moving from one side to the other, and it's not getting oxygenated at all. It's completely avoiding any kind of oxygenation, so it's just blood moving. It's a shunt. So if we compare that to our numbers, okay, so if we say normal is 0.8, dead space is going to be infinity, okay? Because our perfusion is 0, and you can't divide by 0. So ventilation over 0 is a limit. So that means that our VQ is infinity at that point. Oxygenation is whatever it was. So the oxygen isn't changing because it's not contacting any blood. And then we have the shunt. So our VQ with a shunt is 0. Okay, our ventilation is 0. No ventilation, our V is going to be 0 over Q. Okay, so that's, which is 0. All right, and see, in that case we have, yeah, we don't have any ventilation or any oxygenation, deoxygenation, oxygenation. You don't have any gas exchange. Okay, so these can all happen simultaneously and in the lung, and that can really result in hypoxemia, which is low oxygen in the blood. Emia means blood. And hypercapnia, which is high carbon dioxide. All right, so let's talk about control of these things. If we're controlling our rate of breathing, our breathing rate, our depth of breathing, so that's how we kind of control it. Remember, in the heart, we were talking about how fast the heart rate is versus how deeply you breathe, or I'm sorry, how fast the carbon or the heart rate was, and how much blood is pumped out in each stroke, in your stroke volume, how much is pumped out with each beat. So in breathing, it is your rate of breathing and then your depth of breathing, how much air is in each breath. Okay, so it was our minute ventilation. So pretty much the same thing. So we're going to mess with that, and also similar to cardiac, we had mechanoreceptors that were measuring the stretch in the vessels, in the arteries, about how stretched they were to see how much pressure there was. In this case, in the case of oxygen, they aren't mechanoreceptors. They're not measuring stretch. They're chemoreceptors, and they're measuring oxygen, carbon dioxide, hydrogen, those kind of things. They're measuring chemicals. All right, so let's look at what we're dealing with here. So the medullary respiratory center, so it's medullary because it's in the medulla, and it includes the inspiratory center and the expiratory center. So these are two different areas. One is ventral, one is dorsal. So these are two different areas in the medulla, and the inspiratory is causing activation of the diaphragm. Okay. And the expiratory is really just kind of, it's not really necessary during at rest. It's necessary when you're exerting yourself, when you're exercising, something like that, running, where you need to push air out. Because remember, the diaphragm is for inspiration, so breathing in. Okay. So we talk about this inspiratory center, and what it does is through this nerve called the phrenic nerve, it activates the diaphragm. So it will send a number of action potentials, okay, more rapidly active action potentials, to cause that diaphragm to contract, and then it relaxes. It will stop and the diaphragm will relax. Now, you may have to kick in the expiratory center and cause it to squeeze if your breathing rate is fast enough. But normally what we think of is action potentials and then quiescence or quiet, where it stops, and then action potentials again, and then they stop. And that's breathing. Okay, so that's what's coming out of the inspiratory center. So the inspiratory center controls that basic rhythm of breathing by setting the frequency of inspiration. So it receives input from these peripheral chemoreceptors that we're going to talk about in the carotid and then the aortic arch. So the same place that we saw them for blood pressure. So that's where the chemoreceptors are. So peripheral chemoreceptors. We're going to talk about peripheral and we're going to talk about central chemoreceptors. We're going to start talking about peripheral though. So receives sensory input from those peripheral chemoreceptors and feedback from lung stretch receptors. So we can see how much the lung is stretched. So those are mechanical receptors, but that's not measuring your oxygen. That's just kind of feedback to say, okay, how far have we stretched the lung? Can we stretch it more? That kind of thing. So that inspiratory signal inspiratory center gets these two here. We're going to talk about each one of these individually. So then motor output to the diaphragm via that phrenic nerve to control that rate. Signal is a burst of action potentials like we were just looking at. So burst of action potentials and then silence or quiescence, and then a burst and then quiescence again. All right. Then we have the apneustic center, which prolongs the contraction of the diaphragm, right? So that's going to increase the depth of, so it's going to contribute along with the, along with the pneumataxic center, it's going to contribute to your depth of breathing. Okay. And we know, so apneusis is an abnormal breathing pattern. So it's caused by damage to this region, which is prolonged gas. So it's causing this prolonged gasping, and so damage to that, like with a stroke or trauma, can cause that apneustic breathing. It's usually not a good thing because it means there's damage in that in the medulla, in the brainstem. So regulation of ventilation and peripheral control. So this is where we have our picture here. So the carotid body or the aortic body is where the oxygen sensor is, releases neurotransmitter when oxygen decreases. So low oxygen causes a increase in nerve conduction. Okay, so more action potentials. So low oxygen means, oh no, we need to increase our breathing rate. More oxygen more action potentials, and then that will then be carried to the inspiratory center. Okay, so information from those chemoreceptors, just like with the cardiovascular reflex, is carried by the glossopharyngeal nerve and the vagus nerve. Now, I'm not so concerned that you know which one comes from where, only that they are involved, but we know that our vagus nerve is involved in parasympathetic activity, so that's going to that's probably something to remember. So signal to the diaphragm is carried by that phrenic nerve. Okay, so that we just saw. So the peripheral chemoreceptors, they can also detect carbon dioxide, but that's going to have a minimal effect compared to oxygen. So what we need to remember here is that when we have low oxygen, okay, that's what's going to trigger this signal to the medulla, okay, to increase ventilation rate. Okay, so I have down here oxygen-gated potassium channel becomes less permeable with low oxygen. So if your oxygen levels are low, then then that's going to cause it can increase the possibility of an action potential. Okay, but it's oxygen gated. Okay. All right. So this is just a kind of a flow chart that takes us through it. So our point really here is that, and this is how this is how it's practical in the world, is that if your oxygen levels are low, then you want to increase your breathing rate and you want to increase your depth of breathing, so your ventilation depth and rate. So if you have low inspired, so if you're in an area that doesn't have a lot of oxygen, maybe you're at a high altitude, something like that, then your alveolar oxygen is going to be lower, which means it's not going to be able to put as much oxygen onto the blood. Okay, so to be carried by the hemoglobin. So you have low arterial oxygen, partial pressure of oxygen too. So that, as we just saw, is going to increase firing of those peripheral chemoreceptors in the carotid and the aortic bodies. And that then will cause that reflex to the medulla, and you're going to have an increase in ventilation rate and depth of ventilation. Okay? So that's going to increase your ventilation rate. So that's the way it should work, right? If you have low oxygen, you should breathe faster. And this is just learning this whole process is just kind of what happens to make sure that happens. If you're breathing faster, it's probably because you have low oxygen, but it could also be, okay, dun dun dun, if we're moving on, could also just be low pH. All right, so our peripheral was looking at oxygen. Okay. But in the central nervous system, it's kind of indirectly looking at carbon dioxide, because carbon dioxide, high carbon dioxide, is going to lead to high hydrogen, which high hydrogen is low pH. Okay. All right. So peripheral oxygen, we're fine with that. Central has receptors for hydrogen. Okay. So we have to know this relationship to high carbon dioxide and high hydrogen levels. And this is the carbonic acid bicarbonate buffering system. Okay. So it's a blood buffer. So carbon dioxide will combine with water. So we've seen this before. Carbon dioxide combines with water. It makes this molecule called carbonic acid, which carbonic acid, because it's an acid, it can lose that hydrogen, which it does. And when it loses that hydrogen, then that hydrogen can be measured for pH. Okay? So our pH levels will go down. So it becomes more acidic. Okay? All right. So now hydrogen doesn't cross the blood-brain barrier, but carbon dioxide does. So carbon dioxide is lipophilic. It's small and it's lipophilic, and that tends to get by for things moving into the across the blood-brain barrier. So chemoreceptors in the central nervous system, they're in the medulla, and they're very close to the DRG, that inspiratory center that we've been talking about. So if we have higher carbon dioxide, and we just established that means we're going to have higher hydrogen. That hydrogen binds to those central nervous system chemoreceptors, and then those will activate the inspiratory signal directly. So now we have a situation where we could say a couple of things. We could say, well, high carbon dioxide, it's usually associated with low oxygen. That's true. But high carbon dioxide will cause more rapid breathing. Okay. Now, the great thing about that is that if you breathe more rapidly, you actually you blow off the carbon dioxide. Okay. So your carbon dioxide goes away and it moves that equation to the left. Okay, we're going to look at that again in a little while. So if we look at the processes that take place, numbered 1 through 5, so in the capillaries, you've got your blood buffer, your CO2H2O to your increased carbon dioxide to make more hydrogen. But because carbon dioxide crosses the blood-brain barrier, if it's higher, then it's going to be detected in the brain as a greater hydrogen concentration. The hydrogen is detected by those chemoreceptors, signals to the DRG, or the inspiratory reserve, or the inspiratory center, and you have your increased ventilation rate. Okay. So this is another picture of the same thing. It's showing it here in the capillary, but then the carbon dioxide kind of moves into the carbon dioxide moves into the cerebrospinal fluid. Cerebrospinal fluid, same buffer, same buffering system. Production of hydrogen is going to activate those central receptors, and you have increased ventilation rate. Well, just like we want. Okay, so let's talk about a couple of things we haven't really talked too much about yet. The pneumotaxic center. So the pneumotaxic center sits up here in the pons, and it can turn off inspiration, right? So it can limit the action potential and limits that size of tidal volume, or the depth of ventilation. Right? So you have more control of your depth of ventilation. So we saw that with the apneustic center, and now we can see that with the pneumotaxic center. So that control of depth of ventilation, and it also does help regulate ventilation. All right, not trying to trip you up there, because we basically just have to know how this stuff works. But you do have contributions from other areas. So the ventral respiratory group. So the ventral, remember the DRG is dorsal, and that's inspiratory. So the ventral, which I don't know, nobody ever calls it the VRG, maybe because more happens with the DRG. It's got more control. But anyway, that's the expiratory center. So that means it's active during exertion. So it activates those internal intercostal muscles to kind of help force close your rib cage. It pushes down on the lungs to push that air out more quickly, because the diaphragm doesn't. The diaphragm is just that the elastic recoil. All right, so yep, activates those internal intercostals to help force air out during rapid, heavy breathing, as would occur during exercise. All right, so an overdose of morphine, barbiturates, alcohol suppresses those neurons in the ventral respiratory group and can slow respiration. All right, so let's look at a few examples here, like 4, of what we kind of see as far as responses to either saturation, so this is a saturation curve, or kind of how we compensate for problems, I guess. So this is carbon monoxide. Carbon monoxide is very similar. So if you think of oxygen as being O2, so those are, oxygen is, molecular weight is 16, carbon is 12. They're really pretty similar. So oxygen, and then carbon dioxide and carbon monoxide. Okay. I think I drew that wrong. But anyway, you get my point. They're very similar. At least according to your hemoglobin, they're very similar, because the hemoglobin has actually a higher affinity for carbon monoxide than it does for oxygen. Okay? And that's a problem, because that means if there's any carbon monoxide in the area, right, then your saturation of hemoglobin with oxygen is decreased. Okay, so if we see carbon dioxide in the presence of carbon monoxide, you can only see maybe 50% saturation of oxygen. That's it. And if we think about where we would like to see it, I guess it can drop down to a low of 40 when it's completely deoxygenated, but that's not up here at 100 where we would like to see it. All right. So, CO, carbon monoxide, is an odorless, colorless gas that competes with oxygen for the binding sites on the hemoglobin, has much greater affinity. So oxygen only reaches that 50% saturation, this level, in the presence of carbon monoxide. So symptoms are kind of what we would expect if we don't have enough oxygen. Okay, so this is kind of yeah, it's a hypoxemia kind of a situation, low oxygen. So the symptoms are confusion, respiratory distress, okay, obviously because you can't breathe. The skin becomes red. There's no cyanosis because as far as the heme groups, that heme, when it's bound to oxygen, that's what kind of makes it more of a red color. Well, the heme group, when it's bound to carbon monoxide, also kind of has a red color. So it's not a lack of oxygen. I mean, it is a lack of oxygen, but the heme, as far as it's concerned, has something that it's carrying. So you don't see cyanosis. So you wouldn't see somebody with carbon monoxide poisoning turn blue. So to treat it, hyperbaric treatment. So increase your oxygen levels in the air so much that you can just that you kind of push the carbon monoxide off the hemoglobin. All right, so let's look at this respiratory acidosis and alkalosis. So respiratory acidosis can occur, alkalosis can occur. So we'll kind of keep this a little bit simple. What I think is a good way to remember when it comes to respiration or ventilation, breathing, and its effect on blood pH is that if you hold your breath, your pH will go down. Your blood becomes more acidic. You have a buildup of hydrogen. Okay, so that's what happens when you hold your breath. And that's because the carbon dioxide levels, your cells don't know you're holding your breath. They're still doing their thing. So your carbon dioxide levels are going up, 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 up. And that's pushing that whole equation to the right, which if you push that equation to the right, you have more hydrogen being produced. Okay, you also have more bicarbonate. Okay, so you do have increased bicarbonate, but your pH is going to be lower, more acidic, because of this buildup of hydrogen. Okay. All right, and they're going to be dissociated. Now you can kind of force that equation the other way by adding more bicarbonate, and it'll cause it to bind to the bind to make that carbonic acid. But it's not what we're talking about. We're talking about the moving in the right direction from that buildup of carbon dioxide. So respiratory alkalosis, in our example that we're going to talk about right now, what we're thinking about, is, so if we said that you hold your breath to cause your blood to become more acidic, then let's think of the opposite. How can you make your blood more alkaline, more basic? And that is by hyperventilation. You breathe faster. When you breathe faster, you're blowing off the carbon dioxide. So your carbon dioxide is floating away from the lungs. There it goes. There it goes. All right, so your carbon dioxide is going away when you're hyperventilating. So every time you take a breath, you're sort of diluting the blood, and the carbon dioxide is like, wow, there's no carbon dioxide out there. So in the alveoli, it moves out of the alveoli, out of your lungs, and that's what we're seeing here. Pushes that equation to the left, and the hydrogen and the bicarbonate will bond together, and that hydrogen goes away. Okay, and that's going to raise your pH and cause it to become more alkaline. So that means that just hyperventilating can cause your blood pH to go up. Now, generally, what we think of with the lungs and this feature, okay, it's not a bug, it's a feature, is that it's a way to kind of compensate for other changes that may happen to cause acidosis or something like that. So let's say that you're vomiting out you're vomiting a lot and your hydrogen is going away. Well, one way to respond to that is because if you're vomiting, you got a lot of hydrochloric acid in your stomach. So let's say you're just throwing away acid. So that's going to make your blood become more basic, more alkaline. So it becomes more alkaline, more basic. pH goes up. So one way to handle that would just be to slow the breathing. So yeah, excessive vomiting will make your breathing rate go lower. Okay, so then we see people with the opposite, like like DKA, diabetic ketoacidosis. You have those ketones, and the acidity of your blood really increases. And so to get rid of that acidity, we want to push the equation this way. So that means they're going to be breathing very, very fast, very quickly, very rapid breathing to kind of breathe off that carbon dioxide and get rid of it. And that's going to cause the blood pH to increase in this case. Okay. All right. Those are just kind of a couple of examples. But if you understand this equation and the fact that it can be pushed left to right, and you understand how it's related to pH, I know it's a lot to ask, but that's kind of what it's all about. Excuse me. All right, so a couple of things, then we'll give a couple of more examples. Oh my goodness. All right, I have coffee water here. So red blood cell production. So hypoxia will trigger the production of red blood cells, and that's a very good thing because erythrocytes is how we carry oxygen. So if you have low oxygen, so you're in a hypoxemic environment, so you don't have enough oxygen on your blood, that's all that's being measured. It's actually measured in the kidneys. So low oxygen induces the formation of erythropoietin, and of course erythropoietin is made in the kidneys, and it's released into the blood, and it stimulates the bone marrow to produce more red blood cells. Okay, so that's what we do. That's how this works. If you are in a low oxygen environment, or if your blood is hypoxic for an extended period of time, and it has to be as it goes through the kidney, so it's more of a hypoxemia kind of a thing, low blood oxygen, then that's going to trigger this production of erythropoietin. It's a hormone that causes the increased production of erythrocytes. So if we kind of go through this, we don't have to know all of these details. So hypoxia-inducible factor 1 alpha increases the production, so the messenger RNA and translation of that to produce erythropoietin. So we have increased erythropoietin synthesis, and then we have these pro-erythroblasts. So those are just immature erythrocytes, and then they kick out their nucleus and become mature erythrocytes. So one thing that we can see is in somebody with hypoxemia, low blood oxygen, is that we might see an increase in these erythrocyte blast cells, which are becoming, they aren't functional yet, but they are becoming erythrocytes. So we can see that the body is making them. All right, so how does this matter? So effective altitude on oxygenation. So the reason I went over erythropoietin and I don't know the other thing that we went over, respiration and pH, is so we can kind of look at something like this and we can see all of these details and we can figure out what all of them mean, okay? And then if there are any questions, ask about any one of these. We can kind of piece that puzzle together and say, okay, yes, this makes sense. So if we move to a high altitude area, okay, or we're going on vacation, whatever, for 2 weeks to wherever, high altitude area. So first of all, the pressure overall is going to be lower, and particularly your alveolar pressure is going to be lower in that area because of the lower pressure. So how do we compensate for that? How do we make up for that? Well, we increase our ventilation. Okay? So we see our first question up here is, what is the effect on ventilation? Well, the ventilation is going to be higher because of those peripheral chemoreceptors that are going to say, well, let's make the pressure higher. I'm sorry, let's make the ventilation rate higher. So the effect on blood pH, so to get sufficient oxygen, so the ventilation rate is increased. Okay. Now, what did we say about hyperventilating? If we hyperventilate, what's that going to do to? So we're hyperventilating, or we're breathing faster just to get oxygen in. But a consequence of that, or feature, is that we're also blowing off carbon dioxide. So our carbon dioxide is going away. Well, which direction is blowing away getting rid of our carbon dioxide going to send our carbonic acid and carbonic acid bicarbonate buffer? It's going to send that equation to the left because again, your CO2 is floating away, and that is going to cause your pH to go up because those free hydrogen are going to bond with the bicarbonate. Okay, form that carbonic acid and then move that equation to the left. So your free hydrogen is going away. All right, so that makes sense then. The respiratory alkalosis part makes sense. Decreased oxygen because you have decreased oxygen. Okay. Pulmonary blood flow, you're going to have increased pulmonary resistance because you have the hypoxia-induced vasoconstriction. Remember, that's kind of something that the lungs do. When those alveoli don't have as much oxygen, they kind of close up a little bit, or the perfusion slows down a little bit. So you're going to have more vasoconstriction. In this case, it's going to work nicely because the slowed perfusion is going to allow them to become oxygenated, but it's going to increase resistance. And also you're going to start making more red blood cells, which is also going to increase resistance. Okay. All right, the effect on the heart. Let's see. I think, did we already talk about? Oh, no. Hypertrophy of the right ventricle. That increased resistance is going, so the heart may be beating, the heart will also beat faster. But because of the increased resistance, if we focus on the effect of the lungs, then you're going to, over time, hopefully not on a 2-week vacation, but over time you will have hypertrophy, or the right heart, the right ventricle will kind of thicken and get stronger. Too thick is very bad. Okay, so that can be, pulmonary hypertension. That can be a problem. But in this case, I think we're just talking about compensation. So the effect of hemoglobin reduces. So remember earlier we talked about when you have deoxygenated hemoglobin, you have this DPG that kind of sits up there and stabilizes the hemoglobin when it's deoxygenated. So really what that's telling us is that the DPG reduces the affinity for oxygen. So oxygen doesn't stay on. In the presence of DPG, oxygen does not stay on your hemoglobin as well, which means that for the tissues that need oxygen, that's a good thing, okay? Because your pH isn't as low, okay? Because you're breathing faster, but you can still lose that oxygen to the tissues because of the increase in DPG. Now, that doesn't necessarily help in the lungs, but you also have that slowed perfusion. So I don't know if anybody's done a study on that, but the slowed perfusion is going to allow more oxygenation to take place. All right, and the effect on red blood cell production, we already mentioned that that's going to increase. So hopefully all of these things make sense, and we can answer any questions that might come up about something like this, or these in particular. All right, the effect of exercise on oxygenation. So we can kind of answer some of these. We probably could have answered some of these like when we were 10 years old. Okay, that's stupid, but you know what I mean. So exercise on oxygenation, we know that it increases ventilation. Okay, we've known that since we were 5. So it increases ventilation. It's just that now we really kind of know how, because of those chemoreceptors that are measuring our oxygenation levels. The effect on oxygen, so during exercise, oxygen consumption increases, carbon dioxide production increases, so you have higher carbon dioxide, and your ventilation rate is going to increase. Your arterial blood should be maintained. Your body is built for some level of a fair amount of exercise. All right, so you're built for that. That's how we have evolved. So there shouldn't be a big change in oxygen, shouldn't be a big change in carbon dioxide in arterial blood. So this is blood that has been oxygenated, it's been through the lungs, it's being taken care of. There shouldn't be a change in carbon dioxide, but I like how they put this, or it could be decreased. Because if we look over here, during exercise, your muscle cells are really working, which means they're really pumping out carbon dioxide. Higher increased carbon dioxide leads to increased hydrogen, which is lower pH. Okay. Okay, so we need to remember that relationship. All right. So the effect of on the red blood cell production. Okay, so let's see. Effect on hemoglobin. Let's do one thing at a time. The effect on hemoglobin. Your hemoglobin is going to have a decreased, again, affinity for oxygen, which means that you're going to be able to drop oxygen off to the tissues. So the tissues are going to be able to get more oxygen. You're going to have to deal with that by reoxygenating it in the lungs. You're going to have increased cardiac output, increased pulmonary blood flow. Your VQ is more even in the lungs, so that means you're sort of starting to kind of activate those upper, the upper parts of the lung, the zone 1, zone 2 areas, because you've got higher pressure. So those are going to have better perfusion through the lungs, and you're going to decrease that physiologic dead space. Okay. So you're going to make better, more efficient use of the of your breathing. So, yeah. Yep. Okay. So anyway, that's the last slide for pulmonary. Have a good night, day.